Okay, we'll get going because it's 3 minutes past. Yeah, welcome to this presentation on obstetric emergencies. I don't know what obstetric and gynecology teaching has happened maybe weeks and weeks ago, but this was what you guys requested. So there's this one and something gynecological that I'll probably do next week or the week after. So I tried to include what, when I was going through my notes, flagged up as coming under obstetric emergencies, because I think I've had lectures before where, say, maybe only like the antepartum hemorrhages stuff was covered, and I think there's a lot of different components to it, and I guess like anything really handled badly can become an emergency, but I just tried to cover the main stuff that can be quite confusing to distinguish between in finals, or just things that I struggled to kind of rote learn last year, because I definitely left a lot of my obstetric learn until the last minute for finals, so it's kind of good to have it quite succinct. And I'm going to guess quite a lot of you guys have had well, you're all going to have missed certain placements, so obstetrics and gynecology. If that's the key one that you've missed, then it's hard to get your head around some of the things that are going on, but you're very unlikely to see obstetric emergencies anyway unless you're in very exceptional circumstances, so this stuff is kind of hard to learn by a placement anyway. So cool. As usual, if you've got any questions, ask away in the chat, save them to the end, send them to me privately, whatever you want to do, and I'll try and address them as we're going through or at the end, or I'll see what I can find if I don't know the answer. Hopefully you can all, I believe you can all hear me fine. Cool, so we're going to start with amniotic fluid embolisms. So these are one of the less common of the emergencies that you're going to come across, and one of the less obvious ones in the presentation. So it occurs when fetal cells and amniotic fluid enter maternal circulation and cause a systemic response. And it's a rare but a direct cause of maternal death. Happens in about 2 in every 100,000 pregnancies in the UK. So it's not very common, but it still happens. And we debate the mechanisms through which this happens. So we don't know whether there's involvement of strong uterine contractions, excessive amniotic fluids, such as with polyhydramnios, or disruption of the vessels which supply the uterus. And even more vaguely, we don't have any diagnostic tests for it, any ways of predicting it, or any ways of preventing it, really. So just kind of like with general complications of things, we don't like preeclampsia, sometimes we don't know when it's going to happen, it just sort of does, but not, say, for instance, like with a pulmonary embolus, where we can guess the factors that go towards it. So risk factors that we do know are ones that relate to abnormalities of the amniotic fluid, of the uterus and the placenta. So this can include multiple pregnancies, increasing maternal age, induction of labour, uterine rupture, placenta previa, cervical lacerations, eclampsia and preeclampsia, polyhydramnios, like I just said, that excess of amniotic fluid, and any kind of instrumental or assisted delivery, so instrumental delivery and C-section. Research, like what limited research there is about this, has demonstrated some consistent links between maternal age and induction of labour, increasing the risk of exposing maternal circulation to fetal cells, and consequently making amniotic fluid emboli a more common likelihood, but we don't really fully understand the process. So how can it present? It can look quite similar to anaphylaxis or severe sepsis. So I think amniotic fluid embolus, it's not really something that I ever really had come up in CBLs and things like that, but it's come up quite a lot on past medicine. And when you get a question of a mother who sounds like she's probably having anaphylaxis or severe sepsis, but she hasn't got any of the typical infection markers or the related factors, associated factors you'd expect with these diagnoses, and you've got amniotic fluid embolism as an option, potentially suspect some of these. So most occur in labour, but they can also occur with assisted or C-section deliveries or immediately just after birth. And your typical features are things like shivering, sweating, anxiety, coughing, hypoxia, hypertension, fetal distress, which is normally something that we pick up through monitoring by cardiotocography. I struggle to say that all the way through. And signs like cyanosis, bronchospasm, tachycardia, or arrhythmias. Disseminated intravascular coagulopathy is very often the first sign, and within most patients it will present at some point within 4 hours of the amniotic fluid embolus coming into existence. So it is a diagnosis of exclusion. Your differential diagnoses would be things like pulmonary embolisms, anaphylaxis, sepsis, like we said, eclampsia, myocardial infarction. So generally other causes of emboli. And you're only going to actually get, have I got my second page on this? No, I don't. You're only going to get a definitive diagnosis post-mortem with this, actually, because we don't have that definitive test. And that will happen if you see fetal squamous cells and debris in the pulmonary vasculature. Unfortunately, once mum's died, if you go digging around in the body. So to manage it, in the hope that that doesn't have to happen, we're going to focus our approach on resuscitating the mother. So using an ABCD approach, supportive measures where you need to, like fluids and oxygen, involve other teams. So for instance, you might need haematologists to manage your disseminated vascular coagulopathy, or paediatricians if this is occurring during delivery. Make sure that you're monitoring the fetus and perform a perimortem section. So that is removal of the dead fetus if the mother's compromised and you need to perform CPR on her. So this is one of those ethical instances where the life of the mother comes before the life of the unborn child. Meconium stained liquor. So this isn't really something, I guess, that is as much of an emergency as some of the other things that we're going to discuss, but it can become an emergency, particularly for the fetus. So meconium obviously is basically the poo that babies can have while they're in utero, and some pass it, and it can stain the amniotic fluid, this like weird dull green colour that can be pretty alarming to see. And if they pass this fresh, dark, sticky green meconium during labour, this is quite worrying because generally babies shouldn't really be going for poo during labour, and it can be a sign that there's some kind of stress response, some kind of fetal distress, or some kind of stress that's occurring during labour that's causing that to happen. So it's sort of a response to things, for instance, like eclampsia happening. It can occur quite a lot in postmature pregnancies, so those are pregnancies which go beyond the 40-week upper term limit without fetal distress. So it's not always necessarily a bad thing, but when you see it, you should be quite concerned. So if you've got a baby that is presenting with premature rupture of membranes and you've got meconium stained, like I say, the stuff that comes out of mum when you're thinking her membranes are broken, then you need to immediately induce labour on an obstetrician-led unit, and you need advanced neonatal life support there because there's a good chance that baby's having some kind of fetal distress and something pretty funky is going on. The problem with babies passing in meconium during labour is that it doesn't tend to just come straight out. It then sits around, and there's a chance that they can swallow it basically and get this thing called Meconium aspiration syndrome, where the swallowing of this quite irritant meconium causes pneumonitis. And the way to manage that is to suction it. So there is a little pathway there on the right, which shows a very crude way of monitoring this. So if it's quite thin meconium, just monitor their APGAR score. So their APGAR score is going to be, this is after delivery, by the way. So APGAR scores being those scores that you do to use to assess how the fetus is doing at, I think it's 1 minute, 5 minutes, 10 minutes or something like that after delivery. You guys may have read this and actually know the timings better than me, but if it's a thick or thin with a low APGAR score, then get it suctioned as soon as you can. If there's no signs of respiratory distress, then don't put the baby through the unnecessary trauma of suction, and monitor them for about 12 hours after delivery, just to make sure that they're doing all right and they're not going to suddenly go hypoxic and just end up looking a bit worse. Okay, so shoulder dystocia, moving on from talking about babies and poo. So this occurs where you've got, generally where you've got babies who are big or who've got big heads and things like that. And it's a delay in delivery due to anterior or posterior shoulder impaction, either behind the maternal pubic symphysis or with the posterior shoulder getting impacted upon the sacral promontory. So the sacral promontory is obviously the bit kind of at the back of the spine there, pubic symphysis being the bit at the front. So generally when babies being delivered in the cephalic position, so as you can see in picture 1 there, babies are normally with head facing the spine, and they then rotate around and they get delivered sort of sideways as they are in picture 2. And if there's any kind of problems with the baby being too big, the size of the pelvic inlet, labour being quite delayed, then there's a chance that the baby could get stuck there. And this happens in about 1 in every 200 deliveries. So you can see the little star there on the image in part 2 of this diagram, where it's showing you like when it happens. There's quite a high rate of fetal and maternal morbidity and mortality from them. So in mothers, about 11% of them will get postpartum hemorrhage as a result of this, from the trauma that it causes to them. And about 4% will get a 4th degree perineal tear. So 4th degree perineal tears being the ones where it can go right up to the anal mucosa and tear into that as well. So they're pretty nasty. And where the fetus is concerned, you get brachial plexus injury in about 4 to 16% of them. That variable statistic is just due to different numbers in the reporting of different studies across different countries. And of these, about 10% of the infants that get brachial plexus injury will be left with a lifelong disability, such as Erb's palsy, which again, you can probably do some reading into with neuro notes in addition to this if you want to. So this here details the risk factors for shoulder dystocia, and you can divide them into pre-labour risk factors and intrapartum, or during birth, risk factors. So your pre-labour risk factors are, the main one is a mother who has had a previous instance of shoulder dystocia before. And basically that's just a broad term for saying she's had it before, we don't entirely know why, it's probably going to happen again. Macrosomia, which is where you've got a baby who weighs over 4.5 kilograms, increases the risk, but it still does happen a lot in babies who are of normal weight due to other risk factors. Diabetes increases the risk as well, because we know that insulin is a growth hormone, or is a growth factor, so it's going to increase the risk of macrosomia. And generally worry with babies who have disproportionately bigger heads than the rest of themselves. Large maternal BMI can obstruct the birth outlet, so to speak, and any kind of induction of labour where contractions might not be quite as strong as they would otherwise be is going to increase the risk as well. As for your intrapartum risks, having a prolonged first stage of labour is going to increase the risk because the baby's just spending longer sitting where it shouldn't really be sitting. I tend to kind of think of it as though, even if you can't break down your stages of labour in your head, which again, that's a presentation that we can do at another time if you guys want it. It's just kind of the baby's failing to get the sort of momentum that it should be getting to get out of the let's get out of mum really. And then yeah, secondary arrest, so where we've already had labour going at a good rate, and then usually due to some kind of malpositioning of the baby, or issues with, you know, like structures of mum's pelvis, failure of initiation of contractions, things like that, labour spring progressing well and then it stops. Or a prolonged, like taking too long for mum to come out, for the baby to come out of mum. Any kind of augmentation with oxytocin, because it tends to reduce the urge that mum has to contract naturally, and any assisted kind of delivery as well can increase the risk. So features and management. So generally, you know this is happening when you've got a baby who the head gets delivered, but the rest doesn't. So it could be that the head and the chin were difficult delivering in the first place, which is a sign that there's a good chance the shoulders are going to be pretty hard to deliver too. There's a failure of restitution, which is where the baby doesn't turn on its side, like we saw in picture 2 there on this slide. Or there's this thing called turtleneck sign, which is where the baby's head has come out, but it's going to retract slightly backwards into the pelvis, kind of like a turtle's head going back into its shell, so that the neck is no longer visible. And how do we manage this? So imagine that these managements are in chronological order. So you wouldn't try one of these before you try the other. So the first thing you're going to do, baby's head's out, and you're going to try a little bit of gentle downward traction. This will fail if you've got some true shoulder dystocia. So if that's not working, the baby's shoulder is genuinely stuck. And you're not going to continue doing this throughout, because there's a risk that you're going to make any potential injury to the fetus worse if you keep applying gentle downward traction while you're trying other things. So at this point, you've decided that hasn't worked, you're going to get extra help. So just like you would if you've got a patient in cardiac arrest, this is an obstetric emergency, don't try and manage it on your own. So call for help, whether that be senior obstetrician, senior midwife and paediatrician. You want everyone in attendance, because you're anticipating that there are problems with mum, and baby's potentially going to have problems when he comes out or she comes out. So it's a case of managing 2 patients whenever you've got an obstetric emergency. With your extra help, you can then consider performing an episiotomy. So that's kind of putting an extra, I almost think of it as like deliberately causing perineal tear. So you're just making the vaginal outlet wider and making it easier to get access to do internal maneuvers and giving the fetus more space to leave. If that and subsequent contractions don't work, then you can perform, you can put the mother in what's called the Mcroberts position, which you can see in the picture here, where the mum's going to flex and abduct her legs, bringing her hips towards herself, and it increases the relative angle at which like the pelvis is open and just makes it a little bit more easy for the baby to come out. This is also sometimes referred to as the hyperflexed lithotomy position, with the lithotomy position being that one that you see in like gynecological images where mum's got her legs in the stirrups and then it goes backwards and stuff. If you ever see that, that's what that means. This has a success rate of about 90%, and it's even more successful when you apply what's called suprapubic pressure. So that's where you place your hand sort of just above the maternal pubic symphysis, where the shoulder is going to be displaced, and either you apply a sustained pressure or you sort of rock it. And so doing both of these together is the most successful way we've got of dealing with this problem. If both of these don't work, then you'll try internal maneuvers, and there's a variety of these that, to be honest, you don't really need to learn, but you might see them as options on your MCQ of what the next best step should be. So they can include things like grasping at the posterior arm and hoping that if you pull that, it will pull the anterior shoulder with it. Corkscrew maneuver, where you're literally, well, that is what you're going to be trying to do with the baby to get it to wriggle out. And where all of these work, if mum and baby haven't been kind of traumatized enough at this point, then consider rolling mum onto all fours and then repeating the same movements and seeing if this is a more favorable position for mum. And assuming at some point that one of these works, you've then got quite a lot of post-delivery care to do. So you're going to actively manage the third stage of labour. So that is the delivery of the placenta, because if you struggle to get the anterior shoulder out, there's a higher chance that you might struggle to get the entirety of the placenta out, and you don't want any retained products of conception or difficulties there. Afterwards, make sure that you do a PR exam for any third degree tears or just tears in general, because tears are the most common of complications for mothers who are experiencing shoulder dystocia. Make sure you debrief the mother and her birth partners, whether that be dad or a relative or friend or someone else, on what's happened, because it can be quite emotionally traumatic for them, and counsel them on the fact that there's an increased risk of this happening in further pregnancies. Now it's happened once. And also your paediatrician needs to review the newly delivered baby just to see if there's any brachial plexus injuries or fractured clavicles and things like that. And yeah, you've got the complications that tend to happen from this include postpartum hemorrhage, perineal tears. So both of those are where mum's concerned, and where baby's concerned, it's things like Erb's palsy, which is one of your brachial plexus injuries, and fractured clavicles. Umbilical cord prolapse. So this is where you get the umbilical cord, which should usually be sitting kind of nicely around the fetus, and it flows around a little bit, but it shouldn't be getting in the way. And it's where this exits before the presenting part. So by presenting part, we just mean the head, or in breech position, the feet or bottom of the baby, whatever's coming out first. So obviously, as you can see in the picture, this means that the baby's head is probably going to be sitting on the umbilical cord, and the umbilical cord is a vital source of nutrients and oxygen for the baby. So this is going to cause a compromise in fetal blood flow, with subsequent hypoxia and vasospasm, and then you can get irreversible damage or even death of the fetus if this goes on for long enough. And this happens in about 1 in 5,000 pregnancies, and mostly occurs in those who already have ruptured membranes, because it allows the cord to slip down to places that it shouldn't be before the baby's had a chance to actually be delivered. So the incidence of this is low, but mortality is high for babies, mortality is at about 91 in 1,000, due to higher association of cord prolapse in preterm babies, breech babies, and babies who have other underlying congenital defects. We tend to classify this as either occult, which means it's incomplete, where the cord descends alongside the presenting part but not beyond it, or overt, where it's complete and the cord descends past the presenting part and is lower than it in the pelvis. So you can see this in the image on the left hand side there. Or you have what's called cord presentation, where you've got the presence of the umbilical cord between the presenting part and the cervix, but this can occur without the membranes having ruptured. So it can sort of just be sitting in an inconvenient location, but it's not actually really causing us problems yet. So features and risks. So if you get a sudden drop in the fetal heart rate or signs of abnormality on your fetal monitoring trace, such as fetal bradycardia, which can be the only sign, or the cord becoming palpable or visible on examination, and generally in a mother who's got ruptured or absent membranes, then you're going to suspect that this is what's going on. And risk factors of this happening are breech presentation, usually particularly the footling presentation where they're just dangling one foot out for whatever reason, unstable lie of the fetus, so that's why they're moving around all the time and not staying in the cephalic position that we would want them to be in by about 37 weeks. So generally if you've got a mother who is presenting with an unstable lie of the fetus at beyond 37 weeks, you're going to consider them for inpatient admission because of the risk of cord prolapse. Mothers with artificial ruptured membranes are at increased risk, polyhydramnios and prematurity. So how are we going to manage it? Again, as with any of the emergencies, you're going to call for help. This is the one where you'll see questions where it's like, would you consider putting in saline into the bladder? So yeah, consider filling the bladder up because it's going to act to sort of elevate the presenting part and stop the baby coming out. Avoid handling the cord at all to reduce the risk of any vasospasm and further compromise the fetus. And encourage either the left lateral position or the knee chest position, which is what we can see in the image at the back here, where mum's got her head on the pillow. She's got her knees kind of drawn in towards the chest and the bottoms up, because it's just stopping the, it's just anything that stops the effects of gravity, basically. And you can also use drugs called Tocolytics, which can relax the uterus and act sort of prevent encouragement of any further contractions and delivery. And this will just be a kind of temporary measure before you can move the pregnant woman, your pregnant patient, to somewhere where it's where you can have an assisted delivery or a safe delivery. And ideally, if you can, you're going to deliver via emergency C-section, but you can permit a vaginal delivery if you've got a mother who's fully dilated and delivery appears imminent. Because at this point, C-section is not necessarily an option or not necessarily necessary either. Just make sure that you empty the bladder if you have gone about filling it with saline, because that's going to be grossly uncomfortable for mum and also going to make it a lot harder to deliver if this is what's going on. Okay, so eclampsia. So I'm not going to talk about preeclampsia particularly much, but I might quickly just recap it now in this presentation. Just in case any of you guys haven't revised it, but preeclampsia is one of those things that generally mothers can have throughout pregnancy, and for most people it doesn't cause any worry. It's just that sort of unexplained hypertension and proteinuria that mothers can get, usually due to I think it's the spiral arteries not correctly invading the endometrium, and then you get this subsequent release of prostaglandins and hypertension, and they've just sort of got to sort of monitor it, deal with it, put up with it. But the thing that you're worried about is it resulting in any of the complications, but mostly eclampsia, which is where you have at least one convulsion in the absence of other neurological or metabolic causes. Happens in about 5 in 10,000 pregnancies, and the maternal mortality is about 1.8%, and the fetal mortality can be up to 30%. Most seizures that you see occur in the postnatal period. So just after mothers have given birth. So this is why you really want to monitor mothers who have had preeclampsia after they've delivered, but they can also be antepartum or intrapartum during labour. And generally features of it that we see are a new onset of a tonic-clonic seizure. That's like the classical eclamptic seizure, and other features of preeclampsia, so things like frontal headaches, hyperreflexia, nausea and vomiting, generalized edema, right upper quadrant pain, visual disturbances like flashing lights, blurred or double vision, changes in mental state. And you might also have signs and symptoms of HELP syndrome, which is, again, like I'm not going to cover that too much in this because you could go over it if you go over preeclampsia, but it's where you have preeclampsia with hemolysis, elevated liver enzymes, and low platelet count. And about 10 to 20% of preeclampsia patients will present in this kind of way. So yeah, risk factors for it are just basically as for preeclampsia, which is a multi-system disorder developing after 20 weeks with hypertension of at least 140/90 on 2 different readings, or proteinuria, which is normally defined by having a urine dipstick positive for +2 protein in the urine, or 24-hour urine albumin count of at least 300. And that's a miss there. So risk factors, we sort of touched on just then for preeclampsia. I've gone into again here. You can look at this again if you want a little bit more time, but it's things like family history or long intervals between pregnancy, multiple pregnancy, other underlying hypertensions and conditions that might affect your circulation and things like that. Complications of eclampsia are the reasons why we worry about it so much. So it's not so much just that you can have seizures as part of eclampsia, and then that obviously could not be a great thing to have to deal with. As a result of eclampsia and preeclampsia, mothers can get AKI, respiratory distress syndrome, CNS bleeds, death, disseminated intravascular coagulopathy, and fetal complications that arise as a result of it can be intrauterine growth restriction, prematurity, fetal respiratory distress syndrome, fetal death, and placental abruption. So investigations and differential diagnosis. So any differential for this is going to be just any differential for seizures, and this applies both to pregnant women as it would to the rest of the population. So general other causes of seizures could be hypoglycemia, pre-existing epilepsy, head trauma, meningitis, strokes, brain tumour, and just other brain pathology that could cause seizures. Again, like some of this you can cover in neurology more so than here. And how are we going to investigate it? So you're going to do your usual panels of bloods, urine electrolytes. So you might look for raised urea, creatinine, and urate. LFTs, so particularly if it's on a background of HELP syndrome, you might have raised ALT, AST, and bilirubin. You're going to do clotting studies because you want to assess for complications like disseminated intravascular coagulopathy and HELP syndrome. Blood glucose can tell you whether you've got hypoglycemia, which will be a reversible cause of seizures. And abdominal ultrasound and CTG are going to be key in telling us whether we've got any fetal distress and bradycardia. So the image that we've got on the left here is a CTG trace, and the arrows are just showing late decelerations, which it's not an exclusive sign of eclampsia. It's one of the several signs of fetal distress to look out for. And again, like how to read CTGs is another talk in itself, really. So how to manage it? If you're going to remember nothing else, just remember magnesium sulfate is the main thing that we're going to use. So to cause cessation of seizures, that's what we use. And there's a little table here on the right, which I never learned this in kind of this level of detail, but if you're keen to learn it, it goes through what values of and when you're going to use magnesium sulfate from both initiation to at least 24 hours after delivery or the last seizure, which is how long we tend to keep patients on it, just to basically confirm that they're not going to have any, like withdraw it too early and risk them having any more seizures. We also want to control blood pressure. So ideally we want to aim for mean arterial pressure below 120. And we're going to do this with IV labetalol and hydralazine. And the only, the definitive management for this is delivery. So you only really declare eclampsia and preeclampsia over once the baby's been delivered. Just to mention, if you're giving any mothers IV labetalol and hydralazine, make sure that you're doing continual fetal monitoring, both during and for 30 minutes after you've given them, because it can affect the fetal heart rate as well. So you just want to look out to make sure that you're not inducing fetal heart rate problems in the baby while you're trying to manage it in the mother. And back onto delivery, ideally you'll use C-section just because it's a high risk birth, and you'll place mother in the HDU or another supported unit afterwards, but obviously this isn't always possible. And once you've got mum and baby safely delivered in a supportive environment, you're going to monitor their fluid balance to make sure mum doesn't get any pulmonary edema, and just check that she's not getting any AKIs and other complications. You'll check bloods about 72 hours postpartum and regularly check symptoms while mum's still an inpatient. And once you step down to community, you can step down to community once you've reached target blood pressure and mum is asymptomatic. And you're there going to measure blood pressure daily for about 2 weeks postpartum, and again follow up at about 6 weeks. And also, because once mum's had preeclampsia in one pregnancy, she's at increased risk in subsequent pregnancies, so you're going to have to counsel her on this and how to both minimise the risk of it and prophylaxis for it with aspirin in future pregnancies. Uterine rupture. So this is where you have a full thickness disruption of the uterine muscle and underlying serosa, and it typically occurs during labour. So it's rare, but it's associated with significant fetal mortality and morbidity. And we have two types. So we've got incomplete, where you've got peritoneum, the peritoneum overlying the uterus is intact, so the uterine contents will remain within the uterus, or complete. So this is where the peritoneum is also torn and uterine contents can escape into the peritoneal cavity and cause all kinds of problems and irritation and things like that. So risks for this are previous C-section, obstructed labour, multiparity, so that's having multiple children, use of oxytocin and other things to stimulate contractions, previous uterine surgery, particularly C-section, which is the biggest risk factor. For uterine rupture. We tend to find these days that where you've got women who have like your lower section scars, as opposed to the vertical scars that they used to use years ago, it's kind of less likely these days. So features of it can include this variable vaginal pain, which can range from anything from non-specific pain to vaginal, it's like sudden severe pain, and vaginal bleeding, which can be intraperitoneal and therefore just kind of irritant but not actually seen. The feeling that something's given way, unexplained maternal tachycardia, sudden maternal shock or ceasing of contractions, the disappearance of the presenting part, so again kind of like that turtle sign where the head sort of slips back into the vaginal cavity, shoulder tip pain from blood being beneath the diaphragm, vaginal bleeding, and any signs of hypovolemic shock. Just 1 second. Okay, so how are we going to investigate, diagnose, and treat it? And there's a picture here where I'm sort of showing you what it can look like as the tear starts to occur and extend into the vagina. So to investigate it, you're going to use fetal monitoring and ultrasound. To diagnose it, your differential diagnosis, are placental abruption, placenta previa, and vasa previa. And how are we going to monitor it? So if you've got any suspicion of uterine rupture on your CTG, or you know it's happening, consider an emergency section. Call for help, again, it's an emergency. And instigate the massive, if you can and you think it's appropriate, instigate a massive obstetric hemorrhage protocol. And that applies for any of these obstetric emergencies where you're worried there's going to be a potential large amount of bleeding and you want to, for instance, get cross-match blood ready, just in case mum needs a transfusion. You are going to resuscitate, so measures such as protecting the airway, delivering oxygen, putting large bore IV cannula in, and calling for cross-match blood. And then surgical management will be delivery by C-section, and then you're going to subsequently either repair or remove the uterus, so removal of the uterus being hysterectomy. And because this is quite a high-risk procedure for infection secondarily, consider giving prophylactic antibiotics afterwards. So that will be cefuroxime and metronidazole. Uterine inversion. So this is, not that any of these don't already sound nasty, but this is where you've got the uterus that turns inside out following childbirth. It's very rare, and it generally is due to mismanaged stages of labour. So for instance, cord traction, which is applied to an atonic uterus that then can't support itself and subsequently basically falls in on itself. And you can either have a completely revealed or partially revealed inverted uterus, so that's why some of the uterus will remain inside the vagina. And it can lead to vasovagal shock and massive postpartum hemorrhage from uterine atony. The placenta is still attached in about 50% of cases, so it fails to attach and pulls the uterus inside out with it. And risks include previous history of this occurring, fundal implantation of the fetus, uterine atony, and iatrogenic causes of improper third stage management. So third stage being where you're delivering the placenta. And how are we going to manage it? So your usual, your immediate management, intermediate management would be to call for help and do what you can see in the image down here, where you literally grab the fundus and push it back up through. And the aim of doing this isn't to make weird looking images, it's literally to kind of prevent hemorrhage. As nasty as that looks, that is literally what we do. Yeah, your more definitive management is obviously A, B, C, D, E. Transport your patient to emergency theatre where this can be fixed. If your manual replacement fails particularly, then this is what you're going to have to resort to. So consider using replace hydrostatic pressure by infusing warm saline into the vagina, and seal the labour with other hands. So instead of like, whereas in the image here, you've got the hand actually going into the vagina, if you can fill it with fluids instead to sort of balloon it out and then close the vagina or seal it with your hands, that's like another way of doing it before you can get into surgery. And then otherwise, if this fails, consider laparotomy to try and pull the uterus up and out. But generally, this is going to need some level of surgical intervention to repair. Okay, placenta previa. So the next three that we're going to talk about come under the umbrella of antepartum hemorrhage. Although generally, there's a lot of things that can cause antepartum hemorrhage or any bleeding from weeks 24 gestation onwards until delivery. But this placental abruption and vasoprevia are generally considered your main three that you're going to put under this when you're drafting finals notes. So placenta previa is where you've got the placenta either fully or partially attached to the lower uterine segment. And you can see this in the image on the right, where the placenta has formed nicely in the picture on the left, but on the picture on the right, it's quite obviously covering the internal os. So the minute the baby starts to get delivered, it's going to impact on the placenta, not be able to get delivered, and you're going to have a whole host of problems and bleeding from there. So we break it down into 4 grades, but generally you can kind of condense these grades into minor and major. So minor is where the placenta is low, but it's not covering the cervical os, and major is where it is covering the internal os. And just because one is at 1 grade doesn't mean there's a risk that it could become a higher grade as the placenta grows, or become a lower grade, because the placenta does move around a little bit during pregnancy. So in isolation, a low-lying placenta isn't an emergency, but it can be more susceptible hemorrhage due to defective attachment to the uterine wall. And generally, you can have low-lying placentas as a normal thing, but up to and after about 20 weeks, they should be moving up. So it could be picked up on a 20-week scan, and then you're going to want to look out for it again. And if it hasn't moved up, then you're thinking, right, we need to plan for this when we're making the birth plan. So classically, your features, this is the one, they like to have it with placental abruption as a differential, and you need to kind of figure out how you differentiate between the two. But this is the one that's going to cause painless vaginal bleeding of any varying degree. So it could be anything from intermittent spotting for weeks, which gets worse and worse, to this massive hemorrhage. The uterus is usually non-tender, and pain only occurs once labour begins and the fetus starts to impact on the placenta, which is getting in the way. And the placenta can actually cause a breech presentation and transverse lie, because it's disrupting the shape of the uterine cavity and the way that the fetus would lie anyway. So associated factors can be multiparity, which has just meant that the uterus is bigger and therefore things aren't implanting where they normally would. Multiple pregnancies, so being pregnant with twins. Embryos are more likely to implant if you've got scars from C-sections, like at the lower bit. Basically, like if you've got a lower C-section scar, it's a nice, comfortable place for the placenta to embed itself. So if you've had a previous C-section, that's why this is more likely to occur. And differential diagnoses are your other types of antepartum hemorrhage. So placental abruption, Previa, uterine rupture, or a variety of benign and malignant lesions. So these can be things like polyps, carcinoma, or cervical ectropions. Actually, cervical ectropions are one of your main causes of antepartum hemorrhages, and obviously they're just totally benign, and they're generally just due to changes in your levels of hormones during pregnancy. And infections like Candida, bacterial vaginosis, and chlamydia can present this way as well. So how are we going to investigate it? So consider hematological investigation, so full blood count for any maternal anemia, clotting profile. You want to determine what mother's rhesus status is, doing a Kleehauer test in any situation where you're considering hemorrhage can be a risk, because any time that you get potential mixing of maternal blood with fecal blood, you're going to give, if you know mum is rhesus negative, or you don't know the mother's rhesus status, you're going to have to give a dose of anti-D within 72 hours of that event occurring. And that applies for all your hemorrhages and for instances of like abdominal trauma where you don't know if this could have been a thing that's happened, or, you know, potential near missed miscarriages that could have happened and things like that. And do a group and save and cross match if you're anticipating that a transfusion might be needed or a massive bleed is imminent. Do biochemistry, so take a look at UNEs and AFTs. Keep an eye on fetal well-being, so you can do cardiotocography if women are beyond 26 weeks, and do imaging. So ultrasound is your definitive diagnosis, and it'll show a short distance between the lower edge of the placenta and the internal os, because the placenta is obviously covering, most likely to be covering it. So you can see that actually in this diagram here, where the arrow shows the internal os, shows the placenta, and then you've got the arrowhead would show you where the internal os could be. And I would say you can see that it covers it, but I don't think I've ever seen an ultrasound that I'm able to read, and we aren't taught how to read ultrasound scans, so that's something presumably that will come one day. But if one of you here is able to visualize that as like the slice that it is, then there you go, that might be quite useful for you. So yeah, some rules of management. Absolutely do not perform a vaginal examination if you have a mother in whom you suspect placenta previa going into labour, because you're risking, if you do that, potentially lodging it and causing causing that kind of placental abruption and postpartum hemorrhage. And how we're going to manage it: use an ABCD approach in any woman with significant antepartum hemorrhage. Instigate your hemorrhage protocol, and just remember that it could be a thing that you identify in up to about 5% of asymptomatic patients in that 20-week scan that we were talking about. So you'd repeat the scan at 36 weeks if it's identified as a minor placenta previa, or at 32 weeks if it's major, and plan your delivery from there. C-section is really the only method of delivery that we've got, because obviously that means that the baby isn't going to be trying to attempt to get through the internal os, and this is usually done elective at 38 weeks. And as we said in the previous slide, make sure you administer anti-D within 72 hours if you've got a rhesus negative or mother of unknown rhesus status. So placental abruption, this is the next one of your antepartum hemorrhage series, if you like. This is where all or part of the placenta is separated from the uterus prematurely, so it's kind of just floating around and it can sort of go wherever it likes. It's an important cause of antepartum hemorrhages, and it's thought to be due to rupture of maternal vessels within the basal layer of the endometrium. So we've generally got two types of this as well. You've got revealed, which you can see in the image on the left, which is where the bleeding tracks down to the site of placental separation and drains through the cervix, and you get resultant visible vaginal bleeding. Or you've got concealed, which is where the bleeding remains in the uterus, typically forms a retroplacental clot, which you can see on the image on the right. The bleeding isn't visible, but you do still get all the signs and symptoms and this bleeding, this shock, which seems out of proportion to what you can actually see. So the features of this generally are dark red, painful bleeding if it is a revealed abruption, disproportionate shock, and a woody, hard, tense uterus, which is painful on palpation. And your level of bleeding is going to depend upon whether the abruption is concealed or revealed. So the risk factors for this include previous abruption, intrauterine growth restriction, preeclampsia, abnormal lie of the baby, maternal cocaine use or smoking. So I think it affects how the placenta is able to implant in the uterus. So again, this is another one I've seen in quite a lot of past paper / PassMed questions, they like to throw cocaine use in there as a risk factor, which for whatever reason seems unique to this particular presentation. And other risks include abdominal trauma and thrombophilia. And your differential diagnoses and investigations are going to be as for placenta previa, because these generally are like the two differential diagnoses for one another. And with investigations, you're going to do an ultrasound scan. You're going to investigate, as I just said, as you would for placenta previa, but your ultrasound scan might look like this. So here at A, you can see rectal placental hematoma, and B shows the placenta. So this is showing you a concealed placental abruption. So how are we going to manage it? Again, like you're probably picking up the theme here. So ABCD management, instigate your hemorrhage protocol, emergency delivery, ideally C-section, induce the labour to avoid any further bleeding. Sometimes you can manage them conservatively if it's only a partial or marginal abruption and it's not causing any maternal or fetal compromise, and make sure you give that anti-rhesus D within 72 hours. And here's just a little thing that I nabbed off PassMed that a few of you might have seen, with factors on how to distinguish between placental abruption and placenta previa. So again, these are all things we talked about, and just remember that the shock tends to more be with placental abruption, or at least it's like shock disproportionate to what you're seeing, and there's more complications, and the bleeds tend to be bigger, whereas placenta previa, you tend to get more visible losses, but say not so many abnormalities, kind of in terms of coagulopathies and bleeds, for instance. Some other placental abnormalities that you can get that can be a problem to you at some point, but that we don't tend to necessarily put a definition to, include placenta accreta, which is where you've got the chorionic villi attaching to the myometrium rather than the decidua basalis. So it's so deeply rooted that it can't be separated from the uterine wall. So for instance, it's lodged itself into a C-section scar. Or then you've got placenta increta, where it invades the myometrium, and placenta percreta, where it doesn't just invade the perimetrium, it goes through it, and can enter other structures like the bladder. And in this instance, you've got a hysterectomy indicated because it's sort of completely swallowed and ruined the uterus there. So again, these are words that you might not see in news, but they're sort of worth having an idea what they're talking about, because they're just funky Latin words that come up from time to time in literature. Ruptured vasa previa. So this is really quite a rare one, but it still is worth a mention in the sense of antepartum hemorrhages. And this is where you've got the rupture of fragile blood vessels, which run near the internal cervical os. And you can see a very crude representation of them in the image on the left. So you can see the baby is like, it's obviously not the same as having the placenta lying there, but there's something that the baby's head is lying on, putting pressure on. These are very friable and quite prone to rupture in the right set of circumstances. So it tends to occur after you've had rupture of membranes, when there's rupture of umbilical cord vessels, and it leads to loss of fetal blood and rapid deterioration of fetal condition. It's more common in IVS pregnancies, but it does occur in about 1 in 5,000 pregnancies otherwise. And it usually results in this bleeding, which is painless and moderate. Investigate it as you would for any of the other antepartum hemorrhages. But in this instance, your kind of similar measures to manage and save the mum is usually too slow to save the fetus, because the compromise is usually quite fatal for them. Okay, nearing the end, retain products of conception. So this is where in the 3rd stage of labour, it's generally been delayed for some reason. So generally you consider the 3rd stage of labour delayed if it's not complete by 30 minutes if you've got active management, or 60 minutes if it's got physiological, if it's what you call a physiological 3rd stage, where you aren't actively managing it and you're just going for it. And then for whatever reason you pull the placenta out and you notice when you inspect it that it's incomplete. So there's some products that have been left in utero after childbirth, or a medical or spontaneous abortion. So it's not just with childbirth, it can be with other kinds of evacuation of the uterus as well. So risks of this occurring include medical termination, 2nd trimester miscarriages. So generally like anything where the fetus is getting evacuated before its usual time, placenta accreta, so it's like so deeply embedded that it's hard to get the placenta out, preterm deliveries, older maternal age, low placental weight, induced labours, use of pethidine, which is an older painkiller that we used to use and we don't use so much anymore in labour, and previous uterine surgery. And generally you might notice it where the ultrasound scan identifies remaining pregnancy tissue within utero, so it looks kind of echogenic or heterogeneous compared to the rest of the uterine cavity, and it can cause hemorrhage or fever or infection. So suspect it when you've got a postpartum mother who's got signs of endometritis or hemorrhage, pelvic pain, vaginal discharge and fever. And like I said before, it's where you've got an ultrasound that shows some kind of remaining produce that shouldn't be there, or it's thicker than it should be. And to prevent it, so during the 3rd stage of delivery, encourage mum to hold baby to the skin to kind of encourage continuation of contractions and expulsion of the placenta, or give oxytocin into the umbilical vein and clamp the cord to kind of cut off the supply that the placenta has going for itself and hope that it just drops out. If this doesn't work, you can medically manage it by rubbing misoprostol tablets between the lip and the gum, keeping them there for about 30 minutes and allowing them to dissolve, and hoping that this triggers the evacuation of retained products. But you can get some side effects from this, like chills, nausea and diarrhea. Or you can try getting the mother in the lithotomy position, so that one again where the legs are up, and using ANTT techniques to manually separate the placenta from the uterus with your hand. And then if that's complete, you're going to give oxytocic drugs like cefuroxime with antibiotics, usually cefuroxime and metronidazole, just to ensure that everything has been completely evacuated. If these don't work, then consider vacuum aspiration or hysteroscopic evacuation surgically, and again give anti-rhesus D to any all mothers who you don't know the status of or who are rhesus negative. Postpartum hemorrhage, so more bleeding, more fun. So this is after your mum, after the mother has tried to give birth or during attempted delivery. It's the any blood loss of at least 500 millilitres quantity within the first 24 hours of birth is how we define primary postpartum hemorrhages. And there's a lot of causes of this, and pretty much any of the things that we've already talked about happening during labour can be causes as well. But the primary causes are reduced tone, so uterine atony is actually the primary cause. Tension, so generally when you've got an invasive placenta that tries to stay on, any trauma to the peritoneum, or thrombosis, which predispose to bleeding, are your main causes, and it occurs in about 5 to 7% of deliveries. Uterine atony is a cause of about 90% of these, and risks for this include polyhydramnios, excess oxytocin, multiple births, so twin births or more, and prolonged labour. And secondary postpartum hemorrhage is where you've got at least 500 millilitres of blood loss in the 24 hours. It's like add a day on, and it's any blood loss occurring 24 hours after the first day after birth, if that makes sense. And this generally is due to retained clots or tissues or endometritis. So how to manage this? Use your ABCDE resuscitation, call for help as usual. Give IV syntocin or IV ergometrine or IV carbaprost in the hope that these will sort of ligate your bleeding, I suppose. And then you can manually ligate any uterine or internal iliac arteries that could be bleeding, and consider hysterectomy in really severe cases just to stop the source of the bleeding. So this is, again, one of those complications where it can very quickly kill the mother from bleeding out if you've got an unidentified source of hemorrhage, and there's a good likelihood that mother might end up without a uterus for whatever reason. So yeah, I think that is it for that's it for the abnormalities that I could think of. There might be more that you guys can think of that you want to go and read into, but that's kind of at your whim, really. So I'm going to share the feedback here. I've not produced question sets for this one just because this was quite a big session, so we've already taken about an hour doing this. So hopefully that's right for you guys. Feel free to ask me questions if you've got them, but hopefully it was quite straightforward. And yeah, I'll return with whatever the gynecological request one was that we had last time, if that's what you're keen for. But if if you have no questions, I will close the session, and thanks for listening.